doctors. Dr. Prashant, welcoming you on behalf of HITRO for this webinar on Carbetocin in action, case studies from labor room. This webinar is brought by HITRO Healthcare. HITRO Healthcare has 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio with presence in 126 plus countries. HITRO has got 21,000 employees globally. We are among the largest manufacturers of ARVs, APIs, and FTFs in the world. We have Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. HITRO Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar is on Carbetocin in action. Doctor, you will agree with us that Carbetocin is a drug which is used for prophylaxis of PPH, and PPH is a potentially extremely dangerous condition which has the potential to lead to disaster. While there are many papers published on PPH and the dangers of PPH and the role of Carbetocin in PPH, we always like to have our own doctor's experience, our own experts speak on Carbetocin. For that, today we have got Dr. Guduri Srilatha with us. Welcome, madam. Good evening.
Yeah, good evening all. Good evening all of you, and thanks a lot for giving me this opportunity to talk on a very important drug,
Yes.
which is a panic-free drug for all the obstetricians and the gynecologists.
Yeah.
Actually, only the obstetrician and the gynecologist know what's the war zone in the labor room, and
Yes.
this is an excellent drug which helps us a lot. Yeah.
Yes. Madam
So,
is MBBS from Osmania Medical College, DGO from Nanavati Hospital, Mumbai, ERT Diploma in Embryology Academy for Research and Training, Mumbai, 2010, Diploma in Ultrasound from Ion Donald School of Ultrasonography, 2012, Diploma in Reproductive Medicine from International School of Medicine, Germany, Associated Member of Asian Society of Continuing Medical Education. Professional experience of madam includes obstetric gynecology and laparoscopic surgeon for past 19 years, infertility consultant 15 years in Seri Fertility Clinic. With area of interest, infertility, high-risk pregnancy and recurrent pregnancy loss. Madam, we welcome you to this webinar to share your experience. Thanks,
thank
madam.
you.
Yes.
Thanks a lot. Yeah, thanks a lot. So let us discuss regarding this postpartum hemorrhage, and it's not a daunting event; it's a haunting event in the labor room. Actually, when we can discuss about this, and we all know this is the postpartum hemorrhage, where there is a loss of more than 500 ml of blood during the vaginal delivery, or around 1000 ml in case of cesarean section. We call it a case of PPH. And it is very common and can occur even in women who are not at risk. And the PPH is a leading cause of maternal mortality in very social low economic countries, and a primary cause of nearly is one fourth of all the maternal deaths globally. And it's unfortunate yet common, but it's very common. Each and every gynecologist might have faced a case in their lifetime, definitely a case in their lifetime. And it's a very leading cause of the maternal mortality, accounting for about 35% of all the maternal deaths. And it was in developing countries, it was 240,000 per 1 lakh of live births compared to 16 in developed countries. So we have very poor management facilities in the developing countries compared with the developed countries. And global PPH incidence is 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. And the incidence in India, it's really very bad. The 38% of the maternal deaths are due to the PPH, and 25% of the global deaths. It's almost 1/4 of the global deaths take place in India, and 2/3 of these attribute to the PPH. So India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. Yeah, and the etiology, the main causes of the postpartum hemorrhage, it's very important to remember the 4 T's. the tone, the thrombin, trauma, and the tissue. The tone, uterine atony, when the tone of the uterus is lost and its inability to contract, the inability of the uterus to contract, which may lead to the continuous bleeding. And the second is the thrombin, the coagulation defects, any of the coagulation defects, thrombocytopenias, hemoglobinopathies, sickle cell anemias, all these conditions, they also lead to the PPH. And the trauma during the time of the delivery, causing any tears, birth canal trauma, vaginal tears, fornical tears, uterine rupture, uterine inversions, all this trauma also lead to the postpartum hemorrhage. And tissues, and tissue is the regarding the placental tissue, which is retained inside the uterine cavity, which is to be expelled after the delivery within half an hour. If that tissue is retained inside the uterine cavity, we will face a lot of bleeding. So these are the four T's, which are the causes of the PPH. And the clinical findings in PPH. What do we find in PPH? There's an abdominal tenderness will be there. The uterus will be very lax, and the uterine height will be above the umbilicus. There will be an increase in the abdominal girth, and the we can see the loss of uterine contractions, and slowly the maternal tachycardia. So that's why the maternal parameters are to be recorded very properly before the delivery, so that we can assess what's going on during the in-labor process. And the vaginal bleeding also, we should know what's the normal amount, what's the excess amount, when should we take an action. So there are different levels, degree of shock in the shock levels, if it is 500, that's okay. 500 to 1000 is mild level, and the 1000. Hello, can you hear us?
Yes, madam.
We can hear, madam. In between it was
Yeah,
fighting.
actually.
Yes. Now we
Okay,
can now
fine.
it's clear. Yeah. We'll go back to the earlier slide.
Yeah, the previous slide, I think.
Yeah.
Yeah, so this is these are the different levels, the compensatory levels, mild, moderate, and severe, where we know the 500 to 1000 ml is the normal, where there can be a compensation in our body. So when the blood loss is there, our body automatically starts its compensatory mechanism, and it starts adjusting our blood pressures by increasing the heart rate. So we'll have tachycardia, little palpitations, and the dizziness. When this mild blood loss is 1000 to 1500 ml, where there's a slight fall in the BP, because the heart also loses its control capacity to compensate to make any compensatory action. So there's a fall in the blood pressure, and we'll have the tachycardia continuously, and the sweating, and the weakness. And the moderate level is about 1500 to 2000 ml, where there's in the moderate marked fall in the blood pressure of about 70 to 80 millimeters of mercury. And when then you can see the pallor, oliguria, and the restlessness, all these. And severe is 2 to 3 liters, and there's a profound fall in the blood pressure. The patient may collapse, going to the shock, a hunger will be there, and urea and the urine output, everything will be dropped. Yes, the next slide, please. Yeah, and this is the evaluation. How do you evaluate the postpartum hemorrhage? Then, well, as we have said, which the parameters, the pulse rate, BP, everything, tachycardia, respiratory, oxygen saturations, the vital signs, and the blood loss should be assessed. And at the time of the hemorrhage, the entire genital tract, if there are any injuries, that should be assessed. You should the genital tract check for the lacerations, hematomas, or the signs of uterine rupture. And manual examination for the retained placental tissue should be also done. And the assessment with the bedside ultrasound to check if the uterus is not contracted, and the evaluation of the uterus to check the uterine inversion. Which should be done, and cell volume. Hematocrit should be checked. Platelets and the coagulation studies and the assessment of the fibrinogen should be done simultaneously. The next slide, please. Hello?
Yeah.
Yes?
Yeah, madam.
Yeah. Now the approach towards the postpartum hemorrhage. How how should we tackle the postpartum hemorrhage?
Recording in progress.
Hello? Yeah.
Madam, your voice is echoing, you're locked in from two machines, no? So there's echo in your voice.
Yeah.
Giridhar, can you help, madam?
Yeah. Now it's gone, no, sir?
Now it's gone, yeah.
No, actually the internet connection is unstable. It's like that.
Yes. Now it's okay at this point of time.
Okay, fine. Yeah, and how do we approach? So first we should check the uterine tone. The abdominal palpation should be there done, and the uterus feels, if it is uterus is relaxed, boggy, and soft, then it's a sign of uterine atony. If the uterus is felt above the umbilicus, then that's a sign of uterine. Then as we have discussed, the CBP coagulation profile, urea electrolyte should be done, and the ultrasound is nowadays is a right and left tool which we always use, where we can find out if there is any uterine contractions is not there or not, and if there is any collection in the abdominal cavity also, that can be done. And the management part for the poor uterine atony, we know the uterotonic agents which are commonly used are the oxytocins, prostaglandins, and the ergot alkalis, that's the methyl ligometrin and all that. Then the next is the mechanical uterine balloon tamponade is there, which also controls the PPH. And if there are any tears or trauma, as we have said, the second T, the tears or trauma, we have to check properly, examine properly by keeping the speculums. We should assess from where the bleeding is come. If there is any lacerations, that should be properly sutured. Then we have to say rule out any uterine rupture of any angles, the fornical extension tears or the cesarean section, the incision extending behind or like that, or sometimes the posterior wall of the uterine cavity also it gets stayed up, so that also should be ruled out. And some the extragenital causes where there's a rupture of the ovarian or the splenic vessels should be checked out. And this is all and how to inspect during while the cesarean section. You should just keep out the uterus out of the abdomen, then properly examine anteriorly, posteriorly, laterally, everything. And otherwise, so the ultrasound also helps in case of the normal delivery, where you can find out the any fluid collection in the abdominal cavity, uterine rupture, everything. And repair of the genital, any of the laceration should be properly sutured properly. And the pelvic artery, in case if of doing all this also, if it is not controlled, then as we have all known, the interiliac artery ligation should be done. And if there is any retained placental tissue, the best method is first find out whether it is retained placental tissue, then slowly make the patient comfortable, do the proper investigations, give proper anesthesia, short general anesthesia or the spinal. Then manually, slowly, you should remove out the placenta. If it is the patient is conscious in doing that action, the patient may collapse in the shock. And if there are any coagulopathies, then thrombin act, which is the last T, you should start getting the blood products, and we have to supplement the blood products to the patient. The immediate replacement of the blood and coagulation factors and the platelet should be done. The next slide. Yeah. What's the rationale for this development of this carbetocin in the new heat stabilizer? So the carbetocin, which is the magical drug which has come compared with the oxytocin previously, which we have been used for many years. This oxytocin and ergot alkaloid should be kept in the refrigerator and to avoid the degradation. But regarding this, with this carbetocin, it's very stable at the room temperature. You can keep it anywhere. You can store anywhere you need. You are in the developing countries also, where they don't have any all the refrigeration facilities that can be easily stored, and it's a heat stable formation. The oxidation is not a heat stable formulation, so that's why it has is for around 24 months at 30 degrees and 75% of the humidity also. Its efficacy is not lost. And the previous formulations of the carbetocin should be stored within 2 to 8 degrees, but this never avoids need for the cold. Carbetocin doesn't need any cold chain storage, and it is provided in a vial instead of the ampoules, the oxytocin which we get in our ampoules. This is stored in a vial and easy to load and easy to give. The next slide. What are the uses of heterotonic agents? Yeah, usually some people give at the time of the crowning of the head, sometimes delivery of the anterior shoulder at the end of the second stage of the labor, or sometimes following the delivery of the placenta. The prophylactic prophylactically we have been using all these heterotonic agents since age-old methods in the preventing the PPH and the active management of the third stage of labor. So what are the different molecules? Oxytocin, carbetocin, ergometrin, symptometrin, and the misoprostol. Fine. The carbetocin, it's a next generation drug for PPH molecule. It's a synthetic long-acting analog of oxytocin. With making some small structural changes in the oxytocin, the carbetocin has been formed with few structural changes and with the magical properties of long-standing with the heat stable capacity, and this has prolonged half-life and reduces the enzymatic degradation also, and and it is also used for the prevention of the postpartum risk due to the trinatony. And the posology and the administration: one vial contains 100 micrograms of carbetocin in 1 ml solution for the injection. And the clinical evidence, everything will come to know. This is nowhere non-inferior to the oxytocin. So it is almost action is like oxytocin only, but the advantages as we have discussed, the shelf life is more, the degradation is slow. You can it doesn't need a cold storage, and immediately it comes in a vial form, easy form administration. We have all such advantages compared with oxytocin, but in the mode of action, little carbetocin acts little faster than oxytocin. Yeah. So the study design shows that next slide. So the parameters, there's a comparison between the carbetocin and the oxytocin, that it is nowhere non-inferior to the oxytocin. The blood loss of more than 500 ml or use of any additional heterotonic, its almost efficacy is almost same, 14.5 and 14.4. And if its blood loss is more than 1000 ml, 1%. So this study shows that it's not inferior to the oxytocin, but the frequency of the blood loss of at least 500 ml or use of additional heterotonic agents with carbetocin was proven to be non-inferior with oxytocin. And the use of additional heterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. So what's the conclusion? The carbetocin was not inferior to the oxytocin for prevention of the blood loss of at least 500 ml or the use of additional heterotonic agents. And this Cochrane study also showed 11 studies have been done. We are studying around involving around 2,635 women. This for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need of therapeutic heterotonics compared to the oxytocin. Also, carbetocin is associated with less blood loss compared to the symptometry in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer adverse effects. And the guidelines, different guidelines from different countries. the Canadian guidelines and the Danish, Denmark, Poland country, and the Mexican guidelines, Russian guidelines, all these have advised the carbetocin is one of the important drug which kind of helps us in PPH. And regarding the everyone has a beautiful experience with carbetocin. Yeah, it definitely has given us an immediate uterine contractions, and definitely we can make out the large amount of the blood loss after this giving carbetocin is definitely less compared with the oxytocin, as we have to give multiple doses of oxytocin and it takes little actions, slow action. This has given a beautiful result, actually, my experience. And many all will have such experiences. There's no doubt in that. Yeah.
Thanks very much, madam.
Yeah.
But for how long you have been using Carbetocin?
Yeah, since almost last 3 years, I suppose.
Yeah, and almost that.
Before that we had some little doubts whether to go for that
Correct,
or not.
correct,
But
correct,
once we started using it, absolutely we are
correct,
very
correct.
comfortable. Yeah, the
I-
oxytocin people have syntocin people have started being behind us.
Now, what is
Yeah.
the mode of use you generally use? Is it IV infusion or IV slow dose or IM?
Usually IV infusion.
Yeah,
Sometimes if it is required, any morbid patients whom we suspect the PPH, we give IV bolus dosage.
bolus.
Yeah.
And any side effects you have seen with the drug? You encountered any side effect?
Actually, compared with the actually ergometrins, we have immediate shoot
Yeah,
up
yeah,
of the
yeah.
blood
Correct,
PPH.
correct.
That sort is not frequently seen.
Nothing, nothing.
Yeah.
Good. And although we know any patient can get PPH, we always say expect the unexpected. Like you rightly said, the PPH any patient can get. So
Yeah.
what is the patient profile where doctors can actually anticipate a PPH?
Usually in any PIH cases, pre-eclampsia cases,
Uh,
there are number of patients whom we suspect. Actually, it's a doesn't know the obstetricians panicky situation,
correct, correct.
and we have many of the causes like uterine conditions are there. If there's a uterine atony is there,
Uh,
then where the contractions are not proper.
I suppose any attorney can give to this PPH. Your voice is again breaking.
Labor, we give them yeah,
The
and
voice is
in case
breaking.
of any preterm labor, we give them anti-epileptics. We give and pardon?
Yeah, your voice was breaking
Hello?
in between some time back. Yeah,
Yeah.
yeah.
Voice gone.
No, no, now it is okay. It was breaking in some time back. Now it is okay.
So, any uterine over distension of the uterus like twins, multipartum pregnancy, triplets, twins, they we can suspect, and if there's a retained placenta, and in case of preterm labors also, when we
Correct.
stop when they try to stop the labor pains, then in that case of also there's a risk of getting PPH because the uterus doesn't contract properly, and in case of any instrumental deliveries like outlet forceps or the vacuum deliveries also we face such tears and PPH. We should be ready with our war zone things and all that.
Correct, correct, correct.
And the pregnant conditions like preeclampsia, the HELP syndrome, thrombocytopenia conditions, and all that. And in case of if there's a preeclampsia condition, max self when it is given also,
Yes,
that
that can
all
relax
that
the
all
uterus. Yes,
yeah, that also doesn't contract the uterus. So
correct.
they can also we can face the PPH and some clotting defects as we have known all the hemoglobin.
Patients, yes. Patients with
Mm.
high blood sugar or patients, anemic patients can, the risk is more.
Yeah, anemic
Yeah.
patients, the risk is more, and elderly gravids also
Yes,
nowadays
I
the infertility has come up a lot, and all the gravid patients are little
correct,
elderly-ish, and
correct, correct.
and the prolonged labor, prolonged second stage, and all these conditions. And if there is any infections, also rarely sometimes. So in
Actually,
such conditions also we can
anticipate a PPH.
anticipate PPH.
When would you prefer carbetocin over oxytocin for prevention of PPH? Any specific cases, do you decide that you'll use carbetocin straight away first and not go for oxytocin? I mean, you have been using carbetocin in
Yeah,
almost
where
all
we need an
patients. Yes,
yeah. Where we actually, where we need an immediate action, we'll definitely go for the
yes,
carbidocin instead of oxytocin.
oxytocin,
Yeah,
especially atomic uterus and any patients you are expecting. Can
yeah.
we can we use carbetocin in case of a retained placenta?
Definitely we can
We
use
can.
carbidocin in case of a recent placenta. Yeah.
Any experience you have had in this retained placenta? You
Definitely
used.
we have lots of cases. Sometimes the patient tolerates, will give light sedation and do it.
Okay.
Otherwise, sometimes the patient has to be anesthetized.
Yes.
Yeah, it
Because they
depends
will
on.
go in shock otherwise in during
Yeah, otherwise
delivery.
they go in shock also.
Shock. Yeah.
Sometimes when we are pulling the placenta also the uterine inversion chances will be
Correct, correct,
very
correct,
high.
correct,
The
correct,
inversion
correct.
chances will be very high.
Can we use carbetocin in case of Rh negative mothers?
Yeah, there's I still have some doubt regarding that, but I think that can be used. When we are
Can
using
we?
oxytocin, this can also be used.
You have used anytime you had an occasion to use.
Yeah, we already used. There wasn't no problem at all.
There is no problem at all.
Yeah.
Can a doctor use carbetocin for prevention of PPH if he has used oxytocin for labor induction? I mean, almost all patients will be using labor.
It's used for everyone.
And oxytocin ultimately is our textbook brand. We have been using oxytocin since our college
Yeah,
days. Yes.
without that, no obstetrician.
No.
Without knowing
We
that, no obstetrician will go ahead.
we wouldn't become obstetrician without knowing that. In which cases you would prefer an IV route over IM route, or vice versa? Is there any place for IM route?
If there is any in preeclampsia cases and all that, if there is an extra expulsion of the water fluid into the in such cases, I think it's better to use
IM route.
IM route.
And it may be
Yeah.
even in the peripheries where there are no, I mean, support staff or IV facilities may not be there. IM use could help in them.
Okay, fine.
Again, IM route has got a slightly longer duration of effect.
Okay.
If a patient is not responding adequately with carbetocin, what additional uterotonics you would suggest to use?
Behind the screens, if we talk, we use all sort of
Exactly. I mean,
yeah.
a PPH, one drug, no one is going to use one drug.
No one is
No
happy.
one
We
is.
use all
Yes.
sort of
Yeah,
drugs.
absolutely.
We give intrauterine directly for prostadine also, and all
Yes,
sort
yes,
of
yes.
drugs.
Because
All sort
life,
of
yes,
drugs.
very true. Because life is at stake otherwise, no? I mean,
Yeah,
it can lead to disaster. Everything, including physical measures, drugs,
I know,
everything. Yeah,
I
correct.
know.
What are the advantages of carbetocin over oxytocin? Here, madam, I would like to say, do you have any experience of oxytocin giving an ADH-like effects, water retention, sodium, hyper, all those things?
No, I didn't get you properly.
Oxytocin adverse effects, have you seen any time ADH type of adverse effects like water retention, I mean, sodium, high, low?
Not really
Not
bad.
really,
Not
no?
really bad patients. Yeah.
No, no.
Hmm.
And what is the advantage of
Now in our daily practice here, we never come with such high risk patients. But when
correct?
when while doing post graduation, we get all sorts of very high risk patients.
Right.
They high exposure to the oxygen, then that electrolyte imbalance, water retention, everything will be there.
Correct. And
Yeah. They,
advantage of carbetocin over this prostaglandins, misoprostol or carboprost.
pardon?
Advantage of carbetocin over misoprostol or carboprost.
Yeah. This actually has an immediate action. This
Immediate action.
carbidocin has a very immediate action, and the loading done, everything is easy. The oxytocin ampoules, one postgraduate should be standing there breaking the
Correct.
ampoules continuously loading. So that all advantages.
In this case, madam, do you think a pre-filled syringe of carbetocin would be additionally helpful for you all?
Actually, I'm not comfortable with any of these pre-filled syringes. I don't know why. All the hormones also, I'm
Yes.
not comfortable. I don't know why. Yeah,
Okay.
this is my personal experience. Usually
Absolutely.
patients also complain regarding any of the pre-filled syringes,
Okay.
except for those depots and all that.
Yeah, absolutely.
Mm-hmm.
The advantage of carbetocin over methyl ergometrin,
Definitely will not have that high
blood
immediate shooting
pressure.
of the
Blood.
BP. Yeah. Mhm.
Should carbetocin be kept as a reserve drug or should be first line?
There's no harm in using it as a first
First
line, I
line.
suppose. Yeah.
And how do you compare side effect of carbetocin over oxytocin? Especially efficacy wise is almost the same. We say side effect wise,
Hardly anything actually. No?
very
Yeah, hardly anything.
both
Yeah.
have got. The
Yeah,
greatest
both are.
advantage, I suppose, is doesn't require cold chain, a
Yeah, yeah,
single
it doesn't
injection.
require cold
Yes,
chain. The ampoules, the small ampoules and the vial makes a
yes,
lot
yes.
of difference. And
And
the efficacy, the half shelf life, as we have said, it's around for 2 years.
correct.
Yeah,
All those things will matter more than side effects.
yeah.
At your conclusion, one line take on this for the audience. How do you put carbetocin in practice? What is your place of carbetocin in practice?
Yeah, every obstetrician should definitely use. Once they use, they'll definitely know the beauty of this product. I know while studying, everyone will see the oxytocin action and all that,
Yes,
but
yes,
this
yes.
carbetocin, the beauty of the drug can be appreciated only after you using it.
Right.
Yeah,
Well, madam, thank you so much, sharing your experience. It is
yeah,
this experience which is very useful to our doctors, rather
I,
than it gives them confidence, it gives them an insight into actual carbetocin place in therapy in India and in the
yeah,
places where we practice. Thank you
yeah,
very much.
yeah.
And thanks
Thank you.
all the doctors who took time from the schedule and attended this webinar. Thank you, marketing and sales team of Hitro for conceptualizing, for follow-up and implementing. Last but not the least, well, thank you, IT team for super IT support for this. Thanks once again, madam. Wish you a very good evening and wish you a very happy 2025. Thank you so much.
Yeah, thank you. Wish you all also a happy 2025 and thank you. Thanks a lot for giving this opportunity
Thank
to
you.
talk on a very beautiful drug.
If there's something, we'll come back to
Yeah,
you. Thank you so much.
yeah. Thank you.
Thanks, Giridhar.
Yeah.
Thanks, Priyanka.
Thank
You can
you.
log out, madam.
Thank you. Yeah, thank you, Priyanka.